Okay, so this is part 2 of the recording for fundamentals of nursing on electrolytes. Now, the previous recording had ended at looking at hypocalcemia, and in this particular recording, I'll begin from hypercalcemia. So hypercalcemia is an abnormally high calcium concentration in the blood. Okay, serum levels 10.1 milligrams per deciliter or more, or ionized calcium at 5.1 milligrams per deciliter or more. Now, what causes this hypercalcemia? The levels of calcium in the blood might increase due to a number of factors. Number one, if there is increased intake of calcium, or there is increased absorption of calcium in the GIT, or calcium shifts from the bones into the extracellular space, or there's a decrease in the output of calcium. Now, noteworthy is that patients with cancer often develop hypercalcemia. Why? This is because cancer cells secrete chemicals into the blood that are related to the parathyroid hormone. Now, if you do remember, the role of the parathyroid hormone is that it mobilizes calcium from the bone into the blood. Okay? So because of this characteristic, you find that patients with cancer, okay, will have bones that are demineralized. They will tend to lose calcium from the bone. Calcium will get into the bloodstream. They'll have hypercalcemia. Now, when calcium is lost from the bones become weak, and the patient may develop pathological fractures. That is basically a break in the continuity of the bone caused by forces that would not break a healthy bone. Hypercalcemia also decreases neuromuscular excitability. It causes lethargy. Okay. What about magnesium imbalances? So we have hypomagnesemia. Hypomagnesemia is abnormally low magnesium concentration in the blood. Okay, 1.5 milliequivalents or less. Now, due to decreased magnesium intake or absorption or shift of plasma magnesium to its inactive bound form and increased magnesium output are factors that can lead to a decrease in the level of magnesium in the body. The signs and symptoms are similar to those that will present if a patient has hypocalcemia, because hypomagnesemia also increases neuromuscular excitability. What about hypermagnesemia? Now, hypermagnesemia is an abnormally high level of magnesium in the blood. You will have serum concentration of magnesium 2.5 milliequivalents per liter or more. So this can be caused by end-stage renal disease, okay? So if a patient has end-stage renal disease, they'll end up with hypermagnesemia unless they decrease their intake of magnesium to match the decreased output, because in end-stage renal disease, the kidneys are unable to filter magnesium from the body. So the signs and symptoms will be due to decreased neuromuscular excitability, and these will include lethargy and decreased deep tendon reflexes. These are among the most common signs and symptoms. So even when you administer your magnesium sulfate, you are looking out for toxicity, which can be signaled by lethargy or decreased deep tendon reflexes. Let us now talk about acid-base balance. So the term acids describe, or acidosis rather, the term acidosis describes a condition that tends to make the blood relatively too acidic. Okay, now because our cells produce two types of acids, there are two different types of acidosis. So we have respiratory acidosis and metabolic acidosis. Okay, we're talking about acidosis here, where the blood becomes relatively too acidic. Then the term alkalosis describes a condition that tends to make the blood relatively too basic or alkaline. And there are two types of alkalosis: respiratory alkalosis and metabolic alkalosis. Let's begin with the acidosis. We'll begin with respiratory acidosis. So this respiratory acidosis arises from alveolar hypoventilation, okay, where the lungs are unable to secrete enough, or to excrete enough carbon dioxide. Now, any condition that causes hypoventilation, the lungs are failing to excrete carbon dioxide, we end up with respiratory acidosis. So the partial pressure of carbon dioxide rises, creating an excess of carbonic acid within the blood, and that excess of carbonic acid decreases the pH. Then decreased cerebrospinal fluid pH and intracellular pH of the brain cells will cause decreased level of consciousness. That is why patients with respiratory acidosis may present with delirium and then eventually slip into a coma, because once the pH of the cerebrospinal fluid and the pH of the intracellular fluid in the brain reduces, it becomes acidic, then consciousness will be reduced. What about respiratory alkalosis? In respiratory alkalosis, this is where we're saying alkalosis, remember, is a condition where the blood tends to become relatively more basic or alkaline. So it arises from alveolar hyperventilation. Okay, here the lungs excrete too much carbonic acid and water, such that the partial pressure of carbon dioxide falls, creating a deficit of carbonic acid in the blood, causing the blood pH to rise. All right. Now, remember that we've started with respiratory issues. So problems with respiration can cause either acidosis, when there is impaired ventilation, when the lungs are failing to excrete carbon dioxide, you end up with respiratory acidosis. When the lungs are putting out too much carbon dioxide and water, you end up with respiratory alkalosis. Now, when the pH of blood, cerebrospinal fluid, and intracellular fluid increases acutely, cell membrane excitability also increases, giving rise to neuronal symptoms such as excitement, confusion, and paresthesias. You can actually try this. Just start breathing deeply and fast. Breathing deeply and fast. You notice that at some point, you start feeling lightheaded, and you even start feeling as if your extremities are numb, tingling, okay? That is because of respiratory alkalosis. Or when one is, for whatever reason, they are breathing very rapidly, you will notice that you actually feel that there's tingling and numbness in the hands. So if the pH rises high enough, central nervous system depression will occur and the patient might go into unconsciousness. What about the metabolic issues? So metabolic issues can cause metabolic acidosis or metabolic alkalosis. Now, metabolic acidosis occurs from an increase of metabolic acid or a decrease of base. The base in this case is the bicarbonates. So what causes the blood to become more acidic in metabolic conditions is that there is a metabolic acid being produced, okay? So the kidneys are unable to excrete enough metabolic acids, which accumulates in the blood, or the bicarbonate is removed from the body directly with diarrhea. Bicarbonate is a buffer, so it helps to reduce the acidity of blood. It buffers the blood, okay, against acidity, such that if a patient is losing bicarbonate, for example, in diarrhea, then they'll end up with no buffer or very little buffer against acidosis, and they'll end up developing a kind of acidosis called metabolic acidosis. So in either case, the blood bicarbonate decreases and the pH falls. But in hyperventilation, remember, with hyperventilation, rather, the patient will be able to excrete carbonic acids, okay? So metabolic acidosis decreases one's level of consciousness. So with metabolic acidosis, we're just saying that through metabolic processes, there's too much acid being produced. For example, when the cells switch to anaerobic respiration and they produce lactic acid, that is a metabolic kind of acidosis. What about metabolic alkalosis? This occurs from a direct decrease of base, which is bicarbonate, or I mean a direct increase rather, a direct increase of the base, which is bicarbonate, or a decrease of metabolic acids, which increases the blood bicarbonate by releasing it from its buffering function. So in metabolic alkalosis, what we're just saying is that there is a direct increase in the amount of bicarbonate. The bicarbonate is a buffer, so it works against a drop in the pH. If there's too much bicarbonate, the pH will increase. Common causes of metabolic alkalosis include vomiting and gastric suctioning, so you need to be careful. The respiratory compensation for metabolic alkalosis is hypoventilation. Remember that we said the respiratory compensation for metabolic acidosis is hyperventilation. So if a patient has metabolic acidosis, this is where we want to give the patient 100% oxygen in order to increase oxygen supply. If possible, we can even ventilate the patient using a vent. So the decreased rate and depth of respiration allow carbonic acid to increase in the body. That is, if you want to reduce the levels of metabolic acidosis, decrease the rate and depth of respirations. That will allow carbonic acid to accumulate in the body and buffer this particular acidosis, okay? So because bicarbonate crosses the blood-brain barrier with difficulty, neurological signs and symptoms are less severe or even absent with metabolic alkalosis. And let us now talk about assessment of a patient with a fluid or electrolyte or acid-base imbalance. Very briefly, you can take time to just run through the kind of nursing history that you're going to collect. I think I'll be able to just give highlights on what you could focus on. So daily weights, and let's begin with the history rather. So the history, what nursing history do we collect? This nursing history is designed to review the risk factors that could have contributed to this fluid, electrolyte, or acid-base imbalance. Now, ask specific, focused questions to identify factors that could have led to this. So, for example, in relation to the age, when you look at the age of the patient, remember that the very young might easily develop extracellular fluid volume deficits. They may easily develop osmolality imbalances and clinical dehydration. When it comes to the very old, they also might easily develop extracellular fluid volume excess or deficit. They may also easily develop osmolality imbalances. Then environmental factors, patients that take in, you need to find out how much sodium a patient takes. Sodium-rich diets, okay, may lead to extracellular fluid volume excess water retention, because remember, you take in too much sodium. Too much sodium causes increased water retention. So you can look at this table and just see some of the history that you can ask about. Ask about diarrhea, ask about any drainage or vomiting, because that can suggest the possible problems that may arise. For example, diarrhea may cause hypokalemia, may cause hypocalcemia. Drainage from the nasogastric suctioning. Remember, we talked about the patient losing potassium, and the patients might also even lose magnesium from that excess suctioning. Okay. So in terms of the physical assessment, you want to weigh the patient and monitor the fluid intake and output. So if you are monitoring a patient for fluid imbalances, you need to weigh the patient every day using the same weight or the same scale with relatively the same clothes at all the time. And it should be done at least around the same time every day. If it's before the patient eats, that's when you take the weight in the morning. So each kilogram of weight gained or lost overnight is equal to 1 liter of fluid retained or lost. So body weight does not just fluctuate normally overnight. It is not normal. Today you are weighing 50 kilograms. Tomorrow we weigh you using the same scale, the same kind of clothing, the same time as you know, the time we weighed you today. If we find that you've gained 1 kilogram, what that actually means is that you've retained 1 liter of fluid. If we find you have lost one kilogram, that is a sign that you've actually lost 1 liter of water. So that is what we do when we are monitoring fluids, excesses, or fluid deficits by checking the weight. So weigh patients with heart failure and those who are at high risk for those who are at high risk for these imbalances, or those who actually have fluid volume excess, they should be weighed daily. Patients with renal failure, they need to be weighed daily. So daily weights are also useful for patients with clinical dehydration, especially in children, or other causes of risk for extracellular fluid volume. For children that have dehydration, we actually weigh them as we rehydrate them to see how much water is being retained and how much water is being lost, especially those that are malnourished. Weigh the patient at the same time each day, like I said, with the same scale after a patient voids, after they've passed urine. Then the patient needs to wear the same clothes. I mentioned this, or clothes that weigh the same if using a bed scale. Use the same number of sheets on the scale with each weighing. Very important, because with this kind of monitoring, even just a blanket or a bed sheet over the patient, or a thick coat over the patient, will alter the weight and you think the patient has retained some fluids. So compare the weight of each day with that of the previous day to determine fluid gains or losses. Now, measuring and reconciling all liquid intake and output during a 24-hour period is an important aspect of fluid volume assessment. So compare a patient's 24-hour intake with his or her 24-hour output. That fluid balance chart that we use is supposed to be used over a period of 24 hours. So if you open it today at 06 hours, you are going to balance it tomorrow at 06 hours. Okay. The two measures should be approximately equal if the patient has normal fluid balance. To interpret situations in which input and output are substantially different, consider the individual patient. For example, if intake is substantially greater than the output, there are two possibilities. Okay, you find that the intake is higher than the output. It could be that the patient may be gaining excess fluid, or this patient could have lost a lot of fluid initially. So now they are retaining to normal fluid status by replacing the fluids that were previously lost. Or if intake is substantially smaller than the output, you find that the total intake of the patient in 24 hours is less than their output, then there are two possibilities. It could be that the patient may be losing fluids that are still needed by the body. They are being lost from the body, and the patient is developing extracellular fluid volume deficit or hypernatremia. The other possibility could be that the patient is actually returning to normal fluid status by excreting the excess fluid which they had previously gained. So that is how you interpret your fluid balance chart. When there is a deficit, you need to ask, is the input greater than the output, or is the output greater than the input? Then you look at the patient's situation. Did this patient come in with fluid volume excess, maybe due to congestive heart failure? It is normal. In fact, it is expected. It is desired that a patient with congestive cardiac failure who came in with the fluid volume excess should have an input that is less than the output. The output should be greater, because that way you are happy that the patient is losing the excess fluid. So it is not every patient that you should say, the patient has a deficit. They've lost so much fluid compared to what they took in. Some patients, we want them to lose more fluids than they are putting in because they have too much fluids. Whereas for others, we want them to gain more fluids than they are losing because they are dehydrated or they've lost fluids. Okay. So fluid intake includes all liquids that a person eats. That is gelatin, ice cream, soup, drinks, water, coffee, juice, or that the patient will receive through a nasogastric tube or a jejunostomy feeding tube. Whatever you give, as long as it is fluid in nature, it should be documented on the fluid intake part. Now, IV fluids and blood compartments are also sources of intake. If you give an IV fluid, normal saline, Ringer's lactate, or you give blood, it should be recorded on the input or intake side of the fluid balance chart. Now, okay. So, IV fluids and blood compartments are also sources of intake, like I said. Water that is swallowed while taking pills and liquid medications also counts as intake. So it's everything that the patient takes by mouth or by NG tube or by jejunostomy or by IV, okay? A patient receiving tube feeding often receives numerous liquid medication, and water is used to flush the tube. All that water should be measured. So over 24-hour period, these liquids amount to significant intake and should always be recorded on the intake and output chart. Very important. Okay. So the table that is before you here is basically telling you the assessment finding and the possible fluid imbalance. So, for example here, body weight changes from previous day. Let's say loss of 1 kilogram or more in 24 hours. It means the patient has developed a deficit of 1 liter of water actually. Patient gains 1 kilogram, it means a patient has developed an excess. So in your own time, you can take time to look at this particular table, which is in your notes that have already been given to you. What are the nursing diagnoses related to fluid volume? So let's talk about the key nursing problems. There you can come up with nursing problems of decreased cardiac output as a nursing problem, acute confusion, risk for electrolyte imbalance, deficient fluid volume, related to increased output of GI fluids from vomiting and diarrhea, impaired gaseous exchange, risk for injury, okay, and all these others. These are the problems that might arise. These are nursing problems that might arise due to fluid, electrolyte, or acid-base imbalances. What are the goals of care? Goals need to be individualized and they need to be realistic. So for example, with a nursing diagnosis of deficient fluid volume, the following related outcomes may be established for the goals. Some of the outcomes, so even when you write your nursing care plan, some of the outcomes that you might want to put as a goal statement would include the patient will achieve normal hydration status at discharge, okay? The patient will be free of complications associated with the IV device throughout the duration of IV therapy. The patient will demonstrate balanced intake and output measurements within 48 hours of nursing interventions, all right? So whenever you're writing a nursing care plan and you dealing with a nursing problem that involves fluids, balance, fluid excess, fluid deficit, these are some of the goals that you can write depending on the client's situation. So now, our interventions mainly will be to replace the lost fluids and electrolytes. So this is the last part of this recording. Let's now look at parenteral replacement of fluids and electrolytes. So fluid and electrolytes may be replaced through infusion of fluids directly into the vein rather than via the digestive system. Now, parenteral replacement includes parenteral nutrition, where we can give parenteral feeds. It can include IV fluids and electrolyte therapy, crystalloids. When we're giving fluids that also contain electrolytes, these are crystalloids. Then a parenteral replacement may also include giving blood or giving blood components, which we refer to as colloids. Now, IV devices are called peripheral intravenous devices, okay? If the catheter tip, we call them peripheral IVs, peripheral intravenous devices. If the catheter of this device lies in the vein in one of the extremities, peripheral venous cannulas, for example, we call them peripheral IVs. If the tip of the catheter lies in one of the veins of the extremities, then we call them central venous devices. When the catheter tip lies in the central circulation, for example, in the vena cava close to the right atrium, we are going to call that a central line. For example, the ones that we use during dialysis, those are central lines into a major blood vessel nearer to the heart. Then now let us describe the types of fluids. These will be easy because we had already described isotonic, hypotonic, and hypertonic. So an IV solution is either isotonic, hypotonic, or hypertonic. So isotonic solutions have the same effective osmolality as body fluids. Iso means same. So sodium-containing isotonic solutions include, for example, normal saline. These are indicated for extracellular fluid volume replacement to prevent or treat extracellular fluid volume deficit. So when a patient has lost a lot of fluids, usually isotonic solutions will be indicated, such as normal saline. Then hypotonic solutions. Hypo means below or low. Hypotonic solutions have an effective osmolarity which is less than body fluids, thus decreasing osmolality by diluting the blood fluids and moving water into the cells. You give a hypotonic solution, it will shift from the intravascular space, it is going to enter the cells. Then hypertonic solutions have an effective osmolarity that is greater than the body fluids. So if they are administered, for example, if they are hypertonic sodium-containing solutions, they increase osmolality rapidly. And what will happen is they are going to pull water out of the cells into the intravascular space, causing the cells to shrivel or to shrink. So for example, if a patient has cerebral edema, we can give them a hypertonic solution like mannitol, which is going to cause the osmolality of blood to increase, and that will attract water from the swollen brain cells into the intravascular space, thereby reducing the swelling. So here is a table that you can be referring to. It is showing you the hypotonic, isotonic solutions, and also the hypertonic solutions. So I'm sure you may want to know about vascular access devices, VADs. These are catheters or infusion ports that are designed for repeated access to the vascular system, the cannulas that we insert. So devices for long-term use include central catheters, like the ones we insert on patients that are undergoing dialysis, and implant ports, which empty into a central vein. These remain on the patient for a longer period, not just for a few days. The term central applies to the location of the catheter tip, like I had stated, not to the insertion site. It is where the catheter tip is ending. Okay. So because fluids infuse directly into the bloodstream, you need to ensure sterility when inserting these devices. Okay, organize all equipment, and IV equipment includes venous access devices, tourniquets. Generally, we are going to be able to look at establishing IV access, cannula insertion, and IV fluid administration in the skills labs. So this is what we call a cannula, and these are the parts of the cannula. So this is a needle, and the needle is often a metallic rod, but it is surrounded by a plastic catheter or polyethylene catheter. So we have the catheter over the needle. Then this is the bushing, and this one here is the injection port. Okay. Then here we have a valve. This is a one-way valve. Okay. And then we have, we call this the needle grip, and that's the flashback chamber. When you're inserting the cannula, immediately the cannula is in a vein, you're going to see blood appear there. So this is a flashback chamber. Then this is the Luer lock plug, the stopper, as we also call it sometimes, the stopper or Luer lock plug. Then we have the Luer lock connector right there. Then we have the catheter hub plus the wings, these that can fan out. Then we put strapping there, or adhesive strapping. They're referred to as catheter wings. Now, I want to emphasize one point. I have seen people, instead of expelling air from an IV line when they connect it to, before they connect it to a catheter like this, they'll just open the injection port and say, the air will exit through the injection port. That is wrong. This injection port has a valve. It does not allow either air or fluid to exit through it. No, it doesn't. So whatever bubbles are in your IV line, they will go straight into the patient, even when your injection port is open. So take note of that. Expel all the air from the IV line before you connect it to the catheter or the cannula. Okay, so these are parts of an intravenous giving set, which we connect now to the cannula that we've just shown you previously. So it has a Luer connector, which is usually covered. This is what is connected to the cannula. This is the tubing. Then you find that for certain devices, they have a medicine port or injection port here. So when you want to give an IV drug without stopping the fluid, you just inject it into the injection port there. Then this is the track controller, this one here, okay? That's the V-track controller. And then we have the filter right here. And then this is an access port. Access ports can be used for medications as well, or another fluid can actually be connected there. using that tip. It can be connected there. Then we have the spike, and it is always covered. So the spike should be kept sterile, as well as the lure connector. It should always be kept sterile. Now, where do we insert these cannulas? You need to know the veins. So normally we always begin with the veins that are in the periphery before we move to the veins that are proximal. So we start from the distal veins. These are superficial dorsal veins. Okay, it is very common to use this one, the superficial dorsal veins. And then generally we have veins of the palmar arc. You can use any of them as long as they are straight. Then we have the basilic vein there. It is also very common to use the basilic vein because oftentimes it is straight. Then we have the cephalic veins. These are branches of the cephalic vein. So these also are very good. Then on the inner arm here, mostly we use these surfaces quite a lot. If you can't insert on the distal aspect here, then you come to these. So we have the cephalic vein coming down there, and on the medial aspect here, we have the basilic vein. Then we have the median vein of the forearm, and then the basilic vein comes all the way down there. The vein that connects the cephalic vein to the basilic vein is the median cubital vein, okay? And it is found in the brachial fossa. These are often used if we failed to insert down here or at the distal portion. Also, for collection of blood specimen, the median cubital vein is often a good access point. Then we have the radial vein. It is also often a good access point, especially in difficult cannulations. Complications of complications that are associated with intravenous fluids. I would like that all students read through this. There can be what is called infiltration, where the fluids escape, or there's escape of fluid into the subcutaneous tissue. Okay, when you say the cannula is tissued, what is happening there is infiltration. It means that the needle has dislodged, it is leaking fluid into the tissues. Then another complication is sepsis, where microorganisms invade the bloodstream through the cannula. You can also have phlebitis, which is an inflammation of the vein, okay, due to mechanical trauma from the needle catheter, okay, or chemical trauma from the solution. You give the medication, and the medication bends up the vein. That will cause inflammation of the vein, which is phlebitis. Another complication is formation of clots, which is thrombus formation. Okay, and all these other complications such as speed shock. This is the body's reaction to a substance that is injected into the circulatory system too rapidly. Too rapid rate of infusion will lead to speed shock, where your patient will have pounding headache, they may faint, they may have a rapid pulse, apprehension, chills, etc. So if symptoms develop, here you need to discontinue the fluid, report this to the primary caregiver, monitor the vital signs, use proper IV tubings, and then careful monitoring of the rate of infusion. Check the rate frequently so that you don't end up with speed shock. Volume overload, where there's administration of a large fluid such that it causes fluid volume excess. Air embolism is another complication where air is introduced into the circulatory system. This air embolus can occlude blood vessels that are tiny. So this is the end of this particular recording. Thank you so much.